Thiazide Diuretics. Mechanism, Uses, and Side Effects. Part 1. Welcome to Medical Sciences Unfolded. Today we're diving deep into thiazide diuretics, one of the most commonly prescribed drug classes in medicine, used every day for hypertension, heart failure, and edema. Let's start with the pharmacology. Thiazides work in the distal convoluted tubule of the nephron. That's the segment just after the thick ascending limb where loop diuretics work. In the DCT, there's a sodium-chloride cotransporter called the NCC, or the thiazide-sensitive cotransporter. This channel normally reabsorbs sodium and chloride from the tubular lumen back into the bloodstream. Thiazide diuretics block this NCC cotransporter. When NCC is blocked, sodium and chloride stay in the tubular lumen and get excreted in the urine, pulling water along with them. The result is increased urine output and reduced blood volume, which lowers blood pressure. The main thiazide diuretics you need to know are hydrochlorothiazide, the classic original thiazide, Chlorthalidone, a thiazide-like diuretic with a much longer half-life of 45 to 60 hours, preferred for hypertension, indapamide, another thiazide-like agent with some vasodilatory properties, and metolazone, a powerful thiazide-like diuretic used in resistant edema, often combined with loop diuretics for a synergistic effect. An important distinction: Chlorthalidone and indapamide are technically thiazide-like diuretics, not true thiazides, but they work by the same mechanism and are often grouped together clinically. Now, let's talk about the unique calcium effect. Unlike loop diuretics, which cause calcium wasting, thiazides actually increase calcium reabsorption. Here's how. When sodium reabsorption in the DCT is blocked, intracellular sodium drops. This activates the sodium-calcium exchanger on the basolateral membrane, pulling more calcium into the cell and then into the bloodstream. The clinical result? Thiazides can treat hypercalciuria, excess calcium in the urine, and they help prevent calcium kidney stones. This is the opposite of loop diuretics, which are used for hypercalcemia. The primary clinical use of thiazides is hypertension. They are a first-line antihypertensive agent, particularly in Black patients, elderly patients, and patients with isolated systolic hypertension. They reduce blood pressure in two ways. First, by reducing blood volume. Second, with long-term use, by causing direct vasodilation through mechanisms that are not fully understood. Thiazides are also used in heart failure. Though less potent than loop diuretics, they can reduce fluid overload in mild heart failure or be combined with furosemide for diuretic resistance.
Part 2. Thiazide Side Effects, Electrolyte Disturbances, and Contraindications. Now let's cover the side effects, and there are several important ones to know, especially for exams and clinical practice. The most common electrolyte problem with thiazides is hypokalemia, low potassium. When more sodium reaches the collecting duct because thiazides block reabsorption in the DCT, more sodium-potassium exchange occurs, wasting potassium. This can cause muscle weakness, fatigue, and dangerous cardiac arrhythmias. Always monitor potassium levels and consider supplementation or using thiazides with a potassium-sparing diuretic. Second is hyponatremia, low sodium. Thiazides impair the kidney's ability to dilute urine, so free water is retained, diluting sodium levels. This is actually the most dangerous electrolyte effect. Severe hyponatremia can cause seizures and death. Elderly women on thiazides are at highest risk. Third is hyperuricemia, elevated uric acid. Thiazides compete with uric acid for secretion in the proximal tubule, reducing uric acid excretion. This can precipitate gout attacks. Use with caution or avoid in patients with gout. Fourth, metabolic effects. Thiazides cause mild hyperglycemia by impairing insulin secretion from pancreatic beta cells. This means they can worsen glucose control in diabetics. They also cause hyperlipidemia, with small increases in LDL cholesterol and triglycerides, though this is generally modest and not a major concern clinically. Fifth, hypercalciumia. Because thiazides increase calcium reabsorption, prolonged use can rarely cause elevated serum calcium. Hyperparathyroidism can unmask this effect. Contraindications. Thiazides are contraindicated in patients with anuria, no urine output, since there's nothing to diurese. They should be used cautiously in patients with severe renal impairment because they lose effectiveness when GFR drops below 30 milliliters per minute. Loop diuretics are preferred in these patients. Metolazone is an exception and works even in low GFR states. Drug interactions to know. Combining thiazides with NSAIDs blunts the antihypertensive effect. Lithium toxicity can occur because thiazides reduce lithium excretion. And combining with digoxin is risky. Hypokalemia from thiazides can precipitate digoxin toxicity. To summarize, thiazide diuretics block the NCC cotransporter in the distal convoluted tubule, reduce blood volume and blood pressure, and are first line for hypertension. Their unique feature is increasing calcium reabsorption, making them useful for kidney stone prevention. Watch for hypokalemia, hyponatremia, hyperuricemia, and metabolic effects. Thank you for watching Medical Sciences Unfolded. Subscribe for daily medical education videos.